and my dear students, I welcome you all, and today topic of discussion is GORD. The full name is Gastro Esophageal Reflux Disease. So gastroesophageal reflux disease, it is due to the loss of competence of lower esophageal sphincter. So there is loss of competence of the lower esophageal sphincter, and the competence is affected by obesity, then smoking and alcohol. Stress is the main causative factor. So you can add stress in every disease because stress affects our central nervous system, our brain, and that's how the body, every function is controlled by that superior organ, the brain, central nervous system. So the stress you can add in every disease. So GORD is the gastroesophageal reflux disease, where there is loss of lower esophageal sphincter, loss of competence of the lower esophageal sphincter, and the competence is affected by obesity, alcohol, smoking, stress, and it is related to hiatus hernia. So in chronic or in long-standing cases of hiatal hernia, GORD can occur. So GORD is classified into acute and chronic. So the acute gastroesophageal reflux disease can occur due to the factors like smoking. After smoking or alcohol can be the trigger factor, or stress can be the trigger factor, or the burns. So burns, alcohol, stress and smoking can cause acute GORD. In chronic GORD, the positive factors are hiatus hernia and esophagojejunostomy. So GORD can be classified into acute and chronic. The acute GORD is caused by the alcohol, stress, or in a condition like burns, and the chronic GORD occurs due to the esophagojejunostomy, following the esophagojejunostomy, or following the hiatal hernia. Now this GORD is associated with sliding hernia. We have already done this topic. Sliding hernia is the type of hiatal hernia. So GORD is related and associated with the sliding hernia, and GORD can result in, or the complication of GORD is or the long-standing GORD can result in reflux esophagitis. Now reflux esophagitis is a condition where there is extensive inflammation of the lower end of the esophagus. So this is the esophagus, and that's how the stomach, I'm just making the rough diagram. So the lower end of the esophagus, there is extensive inflammation. Why? Because the loss of the competence of the lower esophageal junction has occurred. Now the contents, the fluid, the acid of the stomach will reflux back into the esophagus. So the reflux of acid back into the esophagus from the stomach will occur. That will cause multiple ulcer formation and extensive inflammation. This condition is known as reflux esophagitis. Now let's understand the etiopathogenesis of GORD or the gastroesophageal reflux disease. The pathogenesis. Now what will happen, because there is loss of competence of lower esophageal sphincter, so the acid will reflux back from the stomach into the esophagus. So there will be reflux of acid. Reflux of acid into the stomach. Into the esophagus from the stomach. So there will be reflux of acid into the esophagus in the lower end of the esophagus. Now that will cause what? Multiple ulcer formation will occur. There will be multiple ulcers along with inflammation. That inflammation will be extensive. There will be erosion of the mucosa, extensive inflammation and irritation and multiple ulcer formation. Now that will cause spasm of the longitudinal muscles. And that spasm will cause or will leads to the or will drawn up the cardia into the thorax. So there will be uplift of the cardia into the thorax because of the spasm of longitudinal muscle. So the cardia will drawn up. Cardia will drawn up into the thorax. So that will cause what? Increased esophagocardiac angle. So there will be increased esophagocardiac angle. So I am just repeating, listen again. So there will be loss of competence of the lower esophageal sphincter, and then there will be reflux of the acid from stomach back into the esophagus in the lower end of the esophagus, and that result, that acid will cause erosion and irritation of the mucosa, and there will be multiple ulcers formed along with the extensive inflammation, and then it will leads to the spasm of the longitudinal muscle, and that spasm of the longitudinal muscle will drawn up the cardia into the thorax. So that's how the sliding hernia occurs, because there will be increased esophagocardiac angle. Now because of this increased esophagocardiac angle, and the cycle will go on, so there will be more reflux of acid. So the increased esophageal cardiac angle will cause more reflux of acid. And so then again the cycle will repeat. There will be influx of acid, then again the whole process, then again the spasm, then again the angle will increase. So that's how this process go on. And later on there will be fibrosis of esophagus. This is the late stage. So in late stage there will be fibrosis. of esophagus. So that will cause what? Shortening. That will result in shortening of esophagus. That will result in shortening of esophagus. The later complications will be stricture and stenosis. So this was the etiopathogenesis. Now just understand the clinical features or the symptoms. So the important symptoms are, there is retrosternal pain. That pain is burning pain. And this burning pain is oftenly get confused with the pain of angina pectoris. So in diagnosis we get confused because in angina also there is burning pain, and this is retrosternal pain, and that get relief by the antacids and also by sitting or in sitting position. So patient will get relief in sitting position and by having the antacids. Now why the patient will have relief in sitting position? Because when the patient will lie down, so in lying down position there will be more reflux of the acid from esophagus, from the lower end of the esophagus back into from stomach into the lower end of the esophagus. So there will be more reflux of acid in the lying down position from the stomach into the lower end of esophagus. So in sitting position patient will get relief. There will be blood in stool and blood sticks of blood in vomit. Sticks of blood in vomit. And that will result in anemia with weakness, lethargy, and you can add many symptoms that are present in condition of anemia: the constipation, the lethargy, weakness, anorexia. These all features which are present in case of anemia you can add on. So besides this, the very important feature is dysphagia. Because of the multiple ulcers and extensive inflammation in the lower end of the esophagus will lead to dysphagia. The late dysphagia is due to the stenosis and stricture of esophagus. So these are the clinical features. Now investigations. In investigations, you have to remember two very important investigations, that are barium swallow in Trendelenburg's position. Barium swallow in Trendelenburg's position. What is Trendelenburg's position? It is the position of head down position. So in that position, that it is easy to demonstrate, and this technique will easily demonstrate the reflux of barium back into the lower part of the esophagus from the stomach, because in lying down position there is reflux of the acids. So in lying down position there will be reflux of barium from the stomach into the lower end of esophagus. So that is very good investigation. Also we will recommend patient for esophagoscopy. So in this investigations, this esophagoscopy will easily reveal the angry and bloody, the ulcers which are formed, and extensive inflammation, erosion that has occurred. So it will reveal the angry bloody mucosa of the lower part of the esophagus. So barium swallow in Trendelenburg position and the esophagoscopy. Now treatment is very much easy, as we have have done the peptic ulcers also. So because there is reflux of acid and there is heartburn, very important feature I forget to mention is heartburn. So the retrosternal pain is burning in nature and patient will complain that he or she is having the acidity and heartburn. So that gets relieved by antacids. So you have to recommend patient to quit smoking, alcohol, avoid stress, and to maintain healthy lifestyle, to eat more fibers. And if the patient is obese, then recommend and convince him to reduce some weight. Then antacids are given. Proton pump inhibitors, calcium channel blockers, and H2 receptor antagonist. So all these are given in the case of peptic ulcer also. So this medicines you have to give. Along with this, you have to convince patient to avoid stress. Now the complications. The complications of GORD can be Barrett's esophagus. Now what happens in Barrett esophagus? There is more than 3 cm of columnar epithelium. So columnar epithelium will be more than 3 cm at the esophagocardio junction. So there will be more than 3 cm of the columnar epithelium. Then this Barrett's esophagus can turn into adenocarcinoma. Also, the complication could be stricture or stenosis of esophagus. So the late dysphagia is due to the stenosis and stricture of the lower part of the esophagus.